Thanks so much, Katie. Okay, next up we have Maria Vasileiadi, also from Toronto at the moment, previously from Vienna. I'll leave it up to you.
Perfect. Good afternoon, everybody. Today I'll be speaking about my concurrent ITBS-fMRI work that I've been doing at Sunnybrook Hospital in Toronto. I'll need a clicker, and there we go. So this is work that I've been doing in treatment-resistant depression, so just a very quick short overview about the clinical context. So every fifth person will experience depression at some point in their life, and it's one of the leading causes of disability worldwide. And so we have several pharmacological and psychological treatment options, but many patients do not respond. And in the worst cases, depression can be fatal, so it's very important that we find suitable treatment options for everybody. So now we have TMS, which has been FDA approved as a rapid-acting treatment for depression for several years now. But despite its growing use and all the personalization we're doing, there's still a lot we do not understand, and especially that is about the underlying mechanism. So how does it actually work, and why does it work in some people and not in others? So as I mentioned, personalization, and I'm sure Robin will tell you more about this, there is converging evidence that the DLPFC is our key target for depression stimulation, right? But not all DLPFC locations are equal. So what makes a difference is the functional connectivity between the DLPFC and the SGACC. So this kind of network is the thing that we're targeting. And using resting state fMRI prior to TMS, we can identify individual differences in these connectivities. And this allows us to actually personalize the stimulation site based on the person's connectivity. And Robin has shown before that the closer we are to the optimal site, the better the treatment outcome. However, even with these highly personalized approaches, the response rates remain rather low. And to investigate this heterogeneity, we can use interleaved TMS-fMRI and observe how the brain responds to stimulation in real time. So we can focus here on ITBS, which is a more modern TMS approach that is very short and intense. And still with that protocol, we also see very rather low response rates. And so my goal is to image the online response of the brain and to try and find out if this acute brain response to ITBS is actually a marker for treatment response. And this then could serve as a very powerful, early biomarker to predict who's going to respond to TMS and for who maybe another solution is better. So I'll now talk you through our clinical trial that we conducted at Sunnybrook, and we applied concurrent ITBS-fMRI, so at the same time stimulation and imaging, to better understand this target engagement of the DLPFC-SGACC axis in patients with highly treatment-resistant depression. So the study is set up of a few components, and I'll just quickly walk you through it. So we first recruited our treatment-resistant patients, and as you can see in the right box, the illness duration had an average of 21 years, and they had tried on average 9 different treatments before. So this is just to show that these are very severe cases of treatment-resistant depression. So after recruiting the right patients, we performed a baseline MRI scan. We gathered structural and functional data so that we can personalize their DLPFC targets based on their connectivity, DLPFC SGACC. And then a week later, we performed a TMS-fMRI scan, where we applied both active and sham ITBS inside this camera while acquiring the bold signal to assess the target engagement in real time. After this measurement, patients went on to receive accelerated ITBS treatment at 110% of their resting motor threshold, and you can see the details in the blue box. we continuously assessed clinical administered assessments like the MADRS, so that was our main outcome measurement for depression severity, and we did that right before treatment, right after, at 4-week follow-up and a 12-week follow-up. And so here's a little illustration of how we use resting state fMRI to find the DLPFC site most connected to the SGACC. So you see the group mean on the left, but we used a single subject SGACC connectivity. And in addition to that, we also optimized the E field to induce the highest E field possible in that target. And so this here, I show our experimental setup, which might look a bit daunting, but I assure you it's quite comfortable for the patients. They're very snug inside. The reason why it seems a little bit restrictive is because we really need to restrict the patient's head movement to not have too much motion artifacts in our imaging. So we use the base of a 64-channel head coil, which is used for normal imaging as well. And then we use a 4-channel flex coil arched over the top. And then a 4-channel special coil that you can see here, which is a little gray correlated coil, which is used for neck imaging. But if we place it right on the forehead, we get a really nice signal in the SGACC, which is a very difficult area to get signal from because of the inhomogeneities of the magnetic field. So we really try and enhance our signal there. The TMS coil is somewhere squeezed in between, so it's not pictured here, but it's right on the left DLPFC of the subject, and the imaging coil basically arches around. Now, as I said, we do a sham-controlled design, so we measure the subject with active TMS, and then take them outside of the scanner, put a spacer, as you can see on the right bottom there, to make sure that we don't actually induce an electric field in the brain with a sham-controlled design, and then put the subjects back in. So it's the same location, same session. Basically, subject moved in and out of the scanner to establish these control conditions. This is the clinical protocol that we applied during imaging. So due to our very precise timing, we can have stimulation between EPI slices, which allows for continuous imaging without any artifacts. So we can deliver an actual ITBS protocol as they would receive the next week in their treatment inside the scanner. And then measure the online brain response during imaging. So this is a little bit short about our data analysis. Basically, I can summarize here that we have 2 important ROIs. We have the left DLPFC ROI, which we based on our E field, and we have the SGACC ROI. So both of these are personalized to each subject. So the DLPFC ROI is based on the E field of their personalized target, and the SGACC is based on their free server segmentation of the subject. And we relate the time series within here to our MADRS scores to try and see if they are related in some sense. So without further ado, we'll go on to the results. So first, I show you the clinical results of our trial, right? So pre-treatment, fairly high depression scores. They reduce after 5 days post already, and they stay down until 12 weeks after. Now on the left side here, we see the difference between the SGACC response. So mind you, this is the ROI of the SGACC, so not a whole brain response, between the sham and the active condition. So we see that we actually reduce the activity within the SGACC in the active, whereas the sham does not. This is, and Robin, I think, will tell you maybe a bit more about it, but this is actually the goal of our TMS, is to reduce the activity within the SGACC, so this is good. Here you see that a little bit more in detail, and I can show you these images as well. So on the y-axis, you see the DLPFC target resting state functional connectivity within our SGACC, and we can see that the acute response within the SGACC, which you see on the x-axis, is proportional to the functional connectivity with the DLPFC. So the more negative the DLPFC target, the more negative the response in the SGACC. And the SGACC response actually also predicts the clinical improvement after our ITBS treatment. So the more negative the SGACC response online before treatment, for those patients, you see a higher reduction in the MADRS scores afterwards. So this is kind of evidence to support that the SGACC can be a biomarker for early treatment response. And this highlights the use of this type of neural circuit engagement with TMS-fMRI to guide personalized TMS treatment. So we know now from this clinical trial that SGACC engagement predicts the treatment response. But even if we hit the right target, what does the stimulation intensity do? So we base the stimulation intensity still on the motor cortex, but does this translate to the DLPFC? So then we ask, is there a dose-response relationship within the DLPFC or with stimulation of the DLPFC in the following network? And if so, can we use this to personalize treatment even further? So I'll show you some preliminary analysis on our dose response curves with our TMS-fMRI work within the same cohort. So we had the same cohort or a subset of the same cohort of treatment-resistant patients. We then again had the same setup with interleaved TMS-fMRI, as you can see on the top right. This is maybe a little bit of a better view of our complete setup. We also use neuronavigation to place the coil on the left dorsolateral prefrontal cortex, and we stimulate with different intensities relative to the motor threshold, so 80, 90, 100, and 110%. Mind you, this is a 10 Hertz protocol, so this is not the ITBS treatment that they received. This is a 10 Hertz protocol, which we repeated from a previous study in healthy subjects at the Medical University of Vienna. And here you can see the full brain response. So as I said before, the TMS coil is squeezed in between the head and the imaging coils, which reduces our signal on the left DLPFC, so we can here only see the results on the right DLPFC. So we see an increase in activation whole brain and also in the right DLPFC. However, there's not such a very clear linear response here that we see. But if we look at sham, we don't see any response in the DLPFC at all, which kind of gives us confidence that we did do something right with our sham condition there. If we look at the SGACC, which is one of the most important areas, obviously, that we look at, we see again that the sham kind of does nothing different over the different stimulation intensities, and that with 10 Hertz, actually higher stimulation intensities reduce the activation within this area. So if we then look at the relation between the MADRS change at 5 days post and the dose response within the SGACC, we see that there is no relation at 80%, neither at 90, also not at 100, but at 110%, the acute brain response during TMS with 110% predicts the actual treatment response. And I just wanted to remind you that the patients were treated with 110% of their motor threshold, so this is a match. However, if we look at the individuals, we see completely a huge variety in those response relationships within the SGACC. So on the left side, you see some linear-looking responses. Some are positive, some are negative. On the right side, they're all negative. So I've grouped these together because they are non-responders and they are responders. So we see that the responders generally have a very negative effect at 110%. However, what happened here? Was this maybe not the right target, and did we not reduce the activation in the SGACC for that reason? Or was here maybe the treatment intensity too high, as you do see a negative SGACC activity at 80% and 100%? So these are all very interesting findings, and we can sum up that concurrent TMS-fMRI is a valuable tool in clinical research, and we can see that circuit engagement matters, and by looking at our clinical data, and then in addition to that, we have seen that dose matters as well. So I just wanted to make the point here that we can use concurrent TMS-fMRI to get to the bottom of these questions that kind of leaves us puzzling why some people do or do not respond. And with that, I have to stop because of time. But thank you so much for your attention, and I'm happy to answer any questions now. Okay, so I got a question. How many channels in the carotid coil? 4. So they're very small loops. Did you get good sight of stimulation bolt? Did that correlate with clinical response? Yes. I think. If I got that question right, I think the answer is yes. Then there's another question. Maria, is there an interaction between dose effect and localization targets from the CASH method? I'm not sure how to interpret this question. So if there's an interaction, because all the patients here were stimulated on basically the stimulation side coming from Robin Cash's pipeline. So there was no variation in the stimulation side. However, we can post hoc maybe control for placement error because of the neuronavigation. We do record where we actually stimulated and where the calculated site was. So maybe that is an idea to do, to try and see if the neuronavigated site would differ from the optimal site. So that's an analysis I could do, yeah. Good, I think that was a lot. Thank you so much.